So this segment is really about going deeper into what I've shared earlier on, and that is to give more examples through my perspective. And of course, the example that I will be using will be from the AH experience. Okay, so I will first introduce you to the backdrop of our healthcare practice. This is not new to all of us in Singapore, and that is that we have a very, very rapidly aging society. And the longer we live, the more likely we would have multiple conditions. And that requires us to rethink about reversing care fragmentation, because we've become so good at delivering care that nowadays you have 5 different conditions, you would see 5 different doctors. And that increases healthcare cost. Okay, not to mention the entire patient experience leaves lots to be questioned. Then there are only a few of us, right? Okay, in this room there's us, and then there would be our colleagues who are working in the different workplace. We have a shrinking workforce. This is something that affects all industries. What more healthcare? Because it requires people who are passionate about healthcare to choose healthcare. So very naturally, there'll be lesser. And then you think about it, I've mentioned the point about financial sustainability just now. So if, let's say, you see 5 different episodes at the outpatient versus 1 episode, clearly we are spending more for healthcare. So if you think about it, looking at all of these aspirations, there's a need for us to really drive value-based care even further in the years to come. So with this, I just want to share a little bit about the institution that I practice in. So I'm from Alexandra Hospital. We are a member of NUHS. So Alexandra Hospital as a building is not new. It has got rich heritage behind it. If you read up a little bit more about it, you would know that it has been used as a nesting site for many different healthcare systems prior to NUHS coming on board. So we started our services in June 2018. We will be going up to a maximum of 326 beds in the current building. And that is really because the current building is gazetted for conservation. We will not be doing any modifications to it externally. But what we are doing is we are currently in a phase of campus development in which we'll be building new buildings behind the hospital. So we are situated within the Queenstown precinct, which is one of the oldest neighborhood within Singapore. So we serve very, very old patients. So you can imagine the kind of care that is required when it comes to the kind of patients that would visit AH. So we have been tasked by the Ministry of Health to deliver a new model of care to ensure that healthcare can be sustainable for all in the future. And because of that, I would be elaborating further that our model of care is organized differently in order to support this whole transformation that is a mandate to us. So this is how it looks like. Okay? So most hospitals would be organized by departments or division, like you would have a geriatric ward, you would have a renal ward, a gastroenterology ward, a cardiac ward. It is not the case in AH. We are organized by programs. And what do I mean by that? And that is that for all of our patients, we would look at the population archetype. So most of us would start off life relatively healthy, and we will remain in the well stage. But as we go through life, sometimes we do encounter acute health problems. Some of us have chronic diseases, and then we will age, and then eventually we will reach the end of life stage. So this is how we have organized our services, as you can see from the slide, where it is a deviation away from a typical way a hospital is organized. And why do we do this? Because we are focusing on person-centered care. So an elderly patient who comes in for knee replacement is likely to be under geriatric care, short of the need for orthopedic surgery to come into play for the knee replacements. So this is just an example of how we have organized ourselves so that that patient get that population-specific kind of care from the people delivering the care. So with this, we actually embrace this whole one care team concept where every single patient that AH sees would be held by one team. So we are generalist focused because of the way we are organized. And then there will be patients with different subspecialty needs. So we would have a panel of specialists who would be enhancing care, but that one patient only sees one doctor, even though that patient may have 5 different conditions, because the care is supported by specialists. And should this patient be an inpatient, even if the patient goes through the continuum from being acute to subacute to rehab, we do not move the patient from the bed. So why do we do this? It's so that we can have sufficient time to build relationship for meaningful care to be delivered to the patient, so that the patient doesn't have to repeat his or her story or history 5 different times. And this care team who looks after the patient is formed by different groups of professionals. So at a given time point, depending on the predominant issue for the patient, different providers will take lead. For example, if the clinical issues are largely resolved, but patients have got issues with care transition, coordinating with step-down facility, that will be when the medical social worker would take on the primary role in terms of leading the healthcare team in the care of this patient. So this is something which we embrace, because eventually it is about who is best placed to meet the patient's needs at that given time point. And how we have been able to deliver this is really that we recognize that, in the dire situation, in terms of manpower, there is a need for us to think about how we can use technology to enable and transform the way we deliver care. And it's not to fit into the technology, but more of being informed users of technology. How can we design technology to support us? And like I said, we really are in a very privileged position to build a new hospital. Not every day would nurses get a chance to build a new hospital. So we would then have this duty to really imagine, based on the constraints that we face today, what might it look like if I would have this new canvas to build a brand new hospital for the patients that I'm caring for. So this is something which we hold very dear to our hearts, because you can only get it right. So this is something which a lot of us, we have the opportunity to be part of. And more so when you think about agendas like sustainability, like climate change, how can you build buildings that really would not overtly consume energy, so that we can do our part to really keep the world going. So in the next set of deck of slides, I really will be going into more deeper examples of how Alex Nursing has been, piloting certain initiatives to really push forward the whole idea of value-based care. So again, using this whole way of how we are organized in AH, we came up with a narrative, and that is right. If, let's say, we have this one chance to transform healthcare, what will it mean to nursing practice? So we then agree, right, and everyone wants to do this, that every nurse must be practicing to their fullest extent. So how do we do it? Instead of care being predominantly clinician-led, we would then say that we will define a population of patients that we will lead. And this is working very closely with the doctors in agreement that, as partners, who are we best placed to care for which group of patients? And we would have specialty-based nurses. So a lot of our nurses, they come with different subspecialty. When they practice in AH, again, first and foremost, care is generalist-led. So it requires them to rethink the whole way of working. So our APNs, regardless of what kind of specialty they have, they actually are unit-based. So this is a bit of a difference from how typical hospitals would organize the APN roles. So our APNs are unit-based, and later on I'll share why this is important. And we feel that there is a need for us to think about how we should be shifting nursing care beyond just physical settings. So day in, day out, right? For nurses who work in the inpatient areas, they tend to be so absorbed in all of the different task components, they get lost. And every day is just medication serving, getting changes done and what have you. But somehow, if you think about it, if the future is such that we have technology to enable a lot of these things, if we can refine processes to really preserve nursing time for what really requires nurses to do, then a lot of our time can be channeled more meaningfully into caring for the patients well into the community to keep them well. Again, because the better and more healthier the population is, the lesser likelihood they will need to consume healthcare. So then there's a need for us to really think system-wide that I'm not just a nurse and a ward nurse, that I have a duty to think about how I can influence beyond the boundaries of my practice area. And that is how we have shifted the entire paradigm of Alex nursing to think beyond that, oh, I'm just a nurse practicing in Ward A or Ward B, that I actually have the opportunity to witness and experience how to care for patients across settings. So our approach, having this as a backdrop, is to think about how we can develop and transform nursing practice and the profession, not just to meet present demands. Present demands are just as important, but there will be present unknowns. Who knows what's going to happen next after COVID-19? And then also the future landscape. And what is important is that we do all of these things in a way that is meaningful and sustainable so that we don't burn nurses out, so that we don't have nurses leaving service. So our approach is then to think about these 4 dimensions of how we should be transforming nursing practice, nursing role, nursing empowerment, and enablement. So first and foremost, for nursing practice, there's a need for us to think about how we should deepen the core of generalist nursing practice. So most of us would be prepared at the very foundational level in nursing school. And then when we graduate and we become full-fledged nurses, we would join the workforce, and depending on the area of practice that you're posted to, you will start to be equipped with skills and knowledge that is very pertinent to the area of practice. So if you're an outpatient nurse, you would learn outpatient skills. If you are a specialty nurse, like in the emergency department or OT, you will learn OT-related skills. But we're saying that if you look at the needs of the population, what used to be considered specialty practice, geriatric care, palliative care, chronic disease management, is something that increasingly needs to be seen as generalist nursing practice. And hence, it is about how we can develop nursing education and professional development modules to enable this. So when nurses are able to do this, right, then they are better able to pick up issues that may be more complex, that will require specialty practice. Because behind the support of generalist nurses, we would still have our panel of nurses who are passionate about specialty practice, who are trained at a higher level to be able to deliver care at a higher level for these groups of patients with these corresponding needs. So this allows us to then identify very timely what patients needs. And with this, I would share an example. So typically, most patients in the palliative unit will have no problems getting palliative care promptly, okay? But there may be patients who have palliative care needs, but may not be in the palliative unit. They may be a respiratory patient, they may be a renal patient. Then is it then left to chance for all of these palliative care needs to be picked out? Imagine if that is our loved one. What kind of care would we want to see for this patient? So this is where we feel that it is important as nurses not to leave things to chance. And this is why the need to build generalist practice in these areas, including PAL care, is important, because I may not be a PAL expert, but if I can recognize signs that patients has got PAL care needs, I can then make a referral to the palliative care specialist nurse, who can then be able to give the patient the care that is needed. So these are just examples of why it is important to build this network and to be organized in this manner. There's also a need for us to develop core future skills, and what do I mean? The way we learn no longer just is not just confined to classrooms. In fact, there are everyday opportunities to learn, because the entire practice environment is almost like a live lab. They are real cases of patients that we see, real life experiences and encounters that we learn from patients for different skill set beyond just domain expertise. So there's a need for us to really hone our skills in how we think, how we be agile, how we can really look at a problem and be very persistent in thinking, how can this be done better? So these are all mindset shifts that requires a lot of practice, but also a lot of very deliberate action to build conditions to enable this. And then there's a need for us to think about how might we be a nurse if we have the opportunity to see the same patient who is currently in the hospital pajamas in the home setting. I can guarantee you your perspective will be very different. Yeah, so this is where we feel that there's a need for nurses to just have that view, and in order for them to be able to have that view, they must be enabled to move across different settings to care for patients. And that, in our short 4 years, we have learned that it has been very fulfilling for our nurses. In fact, in contrast to when I first started my nursing practice, I find that nurses today are really a lot more embracing of changes. They actually find a lot of fulfillment in having short stints in different areas because they don't know what they don't know. So then if they have a chance to experience care in different settings, it also gives them the opportunity to identify where their ultimate passion lies. So this is something that we strongly advocate in order to build a very fulfilling nursing practice. So these are examples. So we have a whole group of nurses who are very passionate about geriatric care. So not all of them are geriatric nursing trained. Some, they just love to work with geriatrics. So what they have done is they have taken opportunities to work very closely. So you see in the picture, intergenerational activities that are good for our geriatric patients. Our geri nurses are leading practices in the outpatient as well as in the community. So these nurses, they are not just ward-based, but they have the chance to take their nursing practice in areas that they are passionate about across the setting. And that allows them that view of the whole circle of what geriatric care entails for patients in different settings. So this is something which is very important, which also allows them to work very closely with different professionals. And in fact, because of this, they've been able to create new care processes that are very meaningful, that really adds value to patient care. It also allows them to look at literature and best practices across different countries to see how it can be contextualized for it to be meaningful for nursing practice in Singapore. Another example, and this came from our palliative care nurses, they actually recognize that there is a segment of patients with PAL care needs that currently do not have appropriate services rendered because there is this gap in terms of unmet needs. And because of that, they have worked very closely across institutions and with clinicians to enable patients who may not have that level of needs met to move these patients from the hospital setting, especially when they have wishes to die at home, to transition them safely back to home for their last moments. And these are, again, very, very life-changing moments, not just for the nurses in practice, but we only die once, right? So it is also so important to the loved ones to see that their last moment is spent in the way that the patient wants. So these are actually very, very memorable and insightful changes and that are created by nurses, which again gives us a conviction why the work that we do to allow nurses to practice across setting is so important. So just with this effort, what the nurses have done is able to see that there is a reduction in readmission of patients. And ALEX-NIC stands for ALEX Nurses in the Community. So this is a group of palliative care nurses who are hospital-based, but they also move and transition patients back to home so that patients, and some of these PAL care patients actually have quite high-level needs. They can still be cared for safely so that the relatives are not anxious, and that they can really focus on spending quality time, for the remaining days with the patient, because it is all cared for by the nurses. And this really is very important because these are all moments that only happen once. So the next one, I will go into nursing roles, and that is how we have actually put in quite a bit of effort to match advanced practice resource to unmet priorities. Yeah, so I actually have the opportunity to work with a group of APNs who are really very keen on meeting the population's needs. So some of them, they have subspecialty practice like gynecology, oncology. How more suspect can that be? And yet, as they made the decision to move across to practice in AH, it requires them to broaden their generalist practice. And these are very important because it will then help to support the needs of the nurses who are growing in their practice. We also have psychiatric trained APNs who are actually supporting care of patients in our institution, as well as supporting the growth of nurses. So these are important because it will help us advance nursing forward. And then for those of us who are in nursing leadership roles, some of you may be nurse managers, some may be nurse clinicians, some may be educators. We see the need for these 3 tracks to be unified because while you may continue to hone and develop your domain expertise in your chosen track, all of us collectively have the responsibility to bring nursing forward. We have shared responsibility in staff development, in staff education, in developing a very positive environment so that our nurses can continue to stay with us. And then we also find that even as experienced nurse leaders, there are many who have reached the apex, meaning they have learned all they can in their chosen area of expertise. Then how far more do they grow? They will grow if, let's say, they have another secondary area of interest, and that is where we augment their role by having dual roles offerings. So some of the examples that I would like to share with you. So in this picture, you see that male nurse in the picture. He's Jeffrey. He's one of our advanced practice nurse. He's psychiatric trained. So when he moved over to AH, what he has done is to really beefed up on his generalist nursing practice. And in doing so, on a typical day, how he spends his time is he leads the nurses to actually augment their nursing practice because he is really prepared at a higher level. So he's in a capacity to be able to strengthen our nurses' skills and knowledge. And as an APN, he also puts his practice into good use to the fullest extent by having psychiatric consults in the clinic. He also does lectures across the NUHS cluster to support psychiatric nursing capability. And this is important because then, the words that I will quote from Jeffrey is that he finds that, this really is very fulfilling for him, where he sees that his role as an APN goes beyond just advanced nursing practice and that he can create such a huge impact on the nursing profession through all of the work that he does. And his aspiration is to have zero mental health stigma, not just among patients, but even among staff. So I think it is really about driving that personal aspiration and seeing how meaningful that is in the role that they assume at work that can help us bring nurses forward. Another example, so there's Julie, and this is Ziyan. Okay, so Julie is a senior nurse manager. She's emergency trained. So she used to be based in our urgent care center, and then she got restless because she learned enough about emergency nursing. So she said, okay, I'm very interested in infection prevention and control. So then we actually equipped her with the necessary skills and knowledge, and now she is our nurse lead for infection prevention and control. And as part of her development, she has been moved into the isolation wards because infrastructurally, in terms of process, there's so much to learn. So then now we have Julie who has got dual roles, who can actually function in multiple settings and still find fulfillment in the work that she does. Ziyan is our ANC. She is chronic disease trained. So she used to be ward-based, but because of her chosen area of specialty, she gets a lot of fulfillment looking after patients across settings. So what we've done is to actually enable her to care for more of the patients in the community in our Alex NIC team, and she's currently preparing for her APN studies. So these are examples of how dual roles can actually help nurses craft meaningful roles for themselves, where there is that mutual benefit where they find their role fulfilling, but at the same time they can meet the needs of the organization or of the population. Then the third one is about empowerment. So what we've done is actually create opportunities to build nurses for IGH practice. And this one requires us to collaborate very closely with our clinicians and other providers. We also put in place opportunities to recognize practice advancement, and that is where we would work with our clinicians to create pathways to really empower nurses to practice at a higher level. And in embracing that whole mindset of every Alex nurse a leader, again, we create many learning opportunities where in a whole myriad of roles and responsibilities, nurses have equal opportunities to take charge. Because unless proven otherwise, right, we have to assume that every nurse has the highest potential, then in order to know that, right, we would have to create opportunities, create roles for them to take lead. And last but not least is really about that shared governance structure that I shared earlier on, where this provides that platform, a very meaningful platform for nurses to be able to take charge in making decisions that are in processes that are very close to their hearts. Okay? So this is an example of how we are equipping our nurses. So if you can recall in my earlier sharing, back in 2015, the National Nursing Task Force put out a recommendation to have the assistant nurse clinician roles. So with this role, it is intended for nurses to practice at a higher level. So what our APNs and nurse clinicians have done is to create a curriculum where, because the nurse clinicians and APNs are trained at a higher level, they then teach the nurses. And we work very closely with our chairman medical board and his clinicians to run these learning sessions for our nurses so that they are very, very much more confident in their practice. So they are taught physical assessment skills, they are taught history taking, which then allows them to apply when they care for patients in the clinical setting. So in terms of empowering changes at all levels, another example, and this time from our Nursing Practice and Innovation Council. So earlier on, I shared the need to review processes. So one of the key bugbear for nursing is how much we are spending time on nursing documentation. And then we realize a lot of times we write so much, right? We write long stories, right? We write novels. Who looks at it? No one looks at it. So then there is a need for us to really critically ask ourselves, do we really need to write so much? So the nurses are the ones who said, sister, we're writing too much. No one's looking at our documentation. So what can we do about it? They embarked on this project where they are now in the phase of looking at the different kinds of documentation and removing those that are non-meaningful, non-necessary. And I think this is very important because otherwise we'll be documenting to death and nurses will never go home on time. Okay. Next one is enablement. And that is how we should be shifting technology beyond settings to roles. So we are really good at looking at technology that can help us save time in terms of basic care, having robots to meet different needs, and those are setting-based technology enablement. But if you think about the examples that I shared earlier on, if nurses are starting to practice in different settings, then the other augmentation is to bring in technology that can help them in their roles across settings. So I'll be giving some examples later on. Job redesign. So there may be certain things that is in the task components of nurses today that cannot be automated. It may potentially be something that someone else has to do it. It may not require a trained nurse to do. So that is where there's a need for us to think about how we can do job redesign and yet still ensure these roles are meaningful for the other person taking on. Because who doesn't want to grow in their career, right? So it's important that we take the view that whatever job that we create in terms of redesign, it must be a viable way to grow in different professions. Then there is always the untapped resource, right? But this requires a major mindset shift in all of us. Sometimes as nurses, it is very natural for us to put on a stance that we know more than the caregivers. The fact is we don't know more, okay? Because we are never with the patient throughout the entire life course. We only see the patient during the episode of care. So if we take that view of wanting to really be very inclusive, then we would view the patient's caregivers very differently. And once we are able to do that, it is very highly likely that we can build a trusting relationship. And all of this is done so that we can better care for patients for better value care. Then, of course, to facilitate collaboration beyond boundaries. So I was saying that I'll share some examples. So this is an example of how we have used Google Glass, which is something you can get off the market, to enable nursing practice. So here we have examples of our advanced practice nurse. Wendy is rehab trained, so she had a patient who is on the verge of rehospitalization. So what she's done is, with the use of Google Glass, she's able to do a home visit, and then the rehab consultant in the hospital can view exactly what she's seeing when she does a home visit, and from there we are able to avert a hospitalization episode. And then we also have a picture of one of our enrolled nurse, Annie. She is from the urgent care center. So this was during the heat of COVID, where she actually requires some support and supervision to care for patients in the extended screening facility. So without having to don and doff for different individuals, right, her preceptor can actually view the patient that she's seeing from another location. Then these are examples of how important it is to care for caregivers. So sometimes we assume caregivers are very healthy. What makes us think that a caregiver cannot be someone who is way younger than the adult person? Yeah, so I think there's a lot more we can do to help support caregivers if we are really inclusive so that it is better care for the patient. So what will the future AH look like? Again, I share this model that nurses, there's so much more we can do. And it starts first with us taking a very critical view of our roles today, that what is it that we want to shift? Of course, these things don't happen overnight, but if we can take the view that if I were to change one thing that I'm doing today, to be able to broaden my perspective of the kind of influence my role can bring into healthcare, collectively, there's a lot more we can do. And then as a system, we can really move healthcare forward. Okay, so with this, I thank all of you for attending the session. For those of you who are interested to learn more, exchange ideas, my email is up there because I understand there is no Q&A. Thanks, everyone.
Thank you, Ms. Lee. We have come to the end of this breakout session.